I invite Dr. Preeti Venkatesh. She is the HOD of Fetal Medicine in Manipal Hospital, a very senior practitioner. In fact, she has the privilege of starting fetal medicine in Bangalore. Senior gynecologist, expert clinician, Dr. Lavanya. She is also into cosmetic gynecology. And I also invite Dr. Kanaka Santosh. Please, madam, we will start lighting the lamp.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं
तत्सवितुर्वरेण्यं भर्गो देवस्य।
So somewhere around 2010, India became the capital for diabetes. That means any country that you take, India had a great percentage of people who were suffering from diabetes. I'm not talking about just GDM, I'm talking about the population at large. So it is but natural that our GDM population also is one among the highest. It just doesn't involve the GDM part. It is also the type 2 diabetes part, the type 1 diabetic part, and the GDM part. Now, why that happens in India? Because the age at marriage is increasing, the age at pregnancy is increasing, there is an increasing rate of obesity, but whereas in states like Punjab, it is as high as 40 to 50% of mothers being diagnosed with GDM. We cannot attribute it only to the amount of screening that happens through. It has a great prevalence recording in terms of the genetic predisposition of the population as well. Now, definition of GDM is something which is very simple. An unknown diabetic before the pregnancy starts, and then they become pregnant, and that's the first time probably they are walking into a hospital for all we know, and you know that they are pregnant, you test them, you find that they are diabetic. That person is also categorized as GDM in pregnancy. Now, we can very grossly divide it into type 1, type 2, and gestational diabetic. We all know that type 1 is in the absence or decrease of insulin production, also known as the adolescent or the early onset GDM, the early onset diabetes. Type 2 is because of the abnormal metabolism, which comes later on in age, usually due to insulin resistance, and of course the gestational diabetes, which is an entirely different ballgame. If we want to complicate things further, there is a bigger classification where you can really put it into lots and lots of classifications and probably do a research on it. But for all practical purposes, the first one would count. Now, diagnosis. Just as GDM or diabetes as such is a very varied, very complex, very difficult topic on its own, the diagnosis also has been equally complicated. We have started with something called Sullivan and Mahan method, which we would have all probably heard about in MBBS days. It went into something called as NDD groups. Then came the Carpenter and Custer, which was in vogue for a long time. And then came the Sachs et al. Now, the problem with all these things were that there was no correlation as to, okay, we find out they are diabetic, we treat the diabetic people, and the people who were not treated for diabetes, they still had problems. They still came up with complications of diabetes. So we did put them as non-diabetic, but at the end of the day, the maternal and fetal complications or the neonatal complications still kept on happening. The other problem with it was the difficulty in doing it. The mothers had to come up in fasting, overnight fasting, take glucose, which was quite a heavy load of it. Most of them would puke it out, wait for 2 hours, get poked 3 times, the fasting, the 1 hour, the 2 hour. Many a times it would be just not done, not properly done, or probably not read correctly. So either ways, none of them showed a great difference in the outcome per se. So these are the various ways how it could be done in millimoles rather than the milligrams I gave it before. Then came the 2010 guidelines by the AIDP-SG. Again, the same story, but showed a little difference in terms of the outcomes. And then came the HAPO study. This is something that probably as a PG or as a fellowship student, we had a great time reading about. This was a good study. It involved huge number of women. It had the same thing. It had the same GTT test, which was done between 24 to 32 weeks. But what they did was they recognized women into a series of groups of 7, starting from very low sugar values which were there, to the next set of sugar value, to the next set of sugar value, to the next. They did not classify people as GDM. They just classified people as having this much of glucose, this much of glucose, this much of glucose. And then they studied how progressively the complications increased in the mother as well as in the baby. So they had 2 sets of things. They had a primary outcome which they did and a secondary outcome which they studied for. The primary outcome they studied for was primary cesarean delivery need, neonatal hypoglycemia, birth weight, and the cord serum C-peptide above 90th centile. The secondary things that they studied for was premature delivery, stolen dystocia or birth injuries, intensive neonatal care, hyperbilirubinemia, and pre-eclampsia. And what they found is in almost all of the primary and secondary outcome, as the sugar level increased, whatever be the number, there was progressive increase in the problems to the mother and the baby, which means it is not just one value which is going to be our problem. It is a gradual increase in the amount of maternal glycemic status which is going to be a problem. And after this study, it was almost sure that we cannot put a number to it. It is going to be the monitoring of the mother and the monitoring of the baby and the monitoring of the neonate which is going to bring down our complication, not merely treating the numbers. So a person can have complication at a fasting level of 89, though it is normal, and probably at a fasting level of 119, which is still normal. And probably they may have no complication at a fasting level of 100 and a fasting level of 150 and a postprandial of 150, though they are classified as high risk or GDM patients. So we need to look at the mother, the baby, the fetus and the baby in tandem, not just go by the numbers of GDM. Now coming to the Indian scenario, how easy or feasible is it for us to do the GTT test? Like I said, the woman has to come into the hospital fasting. Definitely not possible in the first visit because they would not know that they want to come visiting in the first visit. And the recommendation is that we do the GTT test or the GDM screening at 2 times. One at booking, whatever time the mother comes into us, and the second time between 24 to 28 weeks. Now at booking, the patient comes, we find that they are pregnant, we tell them you have to do these tests, come back 1 day fasting, overnight fasting, take 75 grams of glucose and do the 3 tests, fasting 2 hour, 1 hour and 2 hour. Again, like I said, it was tedious, it is still probably tedious. There are a good number of my friends who follow it. There are a good number of people who find it very inconvenient like me to ask my patients to do that. Various reasons, both patient and administrative reasons for it. So then came the 1-step 2-hour 75-gram glucose test. This was initially brought out by a group called DIPSI, wherein the advantage, the huge advantage of it was irrespective of the fasting state of the mother. So mother can walk in at any time. It can be even the first time that the mother walks into your chamber saying that my UPT is positive. It need not wait for another day. Directly give up 75 grams of glucose at booking and at 24 to 28 weeks, so that doesn't change. And the threshold of the value was kept at greater than 140 milligram per deciliter. So it is single prick. So you don't have to prick the woman 3 times, 3 different times. Probably more acceptable. And like I said, it is not just about the number, it is about whom we are going to screen. So we are not going to treat that number, we are just going to be a little alert about this mother than probably we are. So we have got our high risk group. Whether or not it is a diagnostic test doesn't matter. We have found out that these people are going to be a little high risk for us, monitor them well. So single prick, single visit at booking and at about 24 to 28 weeks. Now coming to the treatment. The treatment per se, so once you have diagnosed somebody to be high risk for GDM or as GDM per se, it has to be validated. Of course, GTT is one of the tests. It has to be revalidated by giving them information about what they can do with their medical nutrition therapy. Talk to them about what kind of diet they can take. A nutritionist would be at your best side along with such patients. Talk to them about exercises that can reduce diabetic or sugar levels in your blood, and then tell them. So that is about maternal nutrition therapy or medical nutrition therapy, which can to a great extent bring down the levels of sugar without you putting them on any kind of medications. It's just advice, and they're taking care of themselves, which counts at that point of time. Once the person goes through it for about 1 week, 2 weeks, depending on the age of gestation, depending on the high risk that we have, depending on the fetal parameters that we have seen on scans, reassess them using fasting and postprandial values. I prefer doing postprandial for all 3 values of breakfast, lunch, and dinner, but what is recommended is do at least for the fasting value and the post-breakfast 2 hours. Once that is under control, the patient continues to do that, and then you recheck every 2 to 3 weeks, again depending on the gestational age and the risks that the mother has. If they don't go through that, it's still high, then what do? You go into giving oral hypoglycemics. Metformin is one of the tested, tried oral hypoglycemics that you can give. Where they are contraindicated, we are not generally very happy giving to patients who are less than 20 weeks metformin. However, we do have patients on infertility treatment who have taken it in the first 3 months, and we have found that they are quite okay with it. I have personally not seen any larger teratogenicity with metformin. I think Dr. Priyanka and Dr. Lavanya, who do treat infertility, happily nodding their heads saying that metformin is quite safe. And when that doesn't work, or directly when we see that our initial values were about 200, which is directly an indication to start off insulin. Insulins, again, like we all know, there are multiple types of them. The basic ones are the Actrapid and the Mixtard. The newer ones, Levemir, etc., also helps us to reduce the number of pricks for the patient to administer insulin. One of these 3 ways we control their diabetic status. Then what happens? So like I said, the glucose monitoring has to be kept up. We need to be sure that what we have advised is followed through. The FBS, PPBS values are kept at what we want it to be, which is less than 95 and less than 120 if you're doing 2 hour, less than 140 if you're doing 1 hour values. If we are doing MNT or OHA, the type of evaluation is at around 2 to 3 weeks. If the patient is on insulin, it is about 3 to 5 days interval that you will have to do it. In case it is uncontrolled, you will have to make them do it almost daily and do the dose adjustment accordingly. You have to also investigate the patient for associated problems, like are they going in for a renal function failure early or insulin. They say if they are well controlled in whatever ways it is, it can go up to 39, whereas if it is a poorly controlled diabetes, you should deliver them before 38 weeks and 6 days. Now, whether you would deliver them at 36, 37, 38 is dependent on the comorbidities, the way the baby is growing, the Dopplers, the fluids, the evidence of PIH, Doppler changes, etc., etc. If there is vascular complication, if there is a retinopathy, or if there is a neuropathy, then it becomes very important that we deliver the baby as soon as it reaches viability. Now, viability defined by the NICU that you have. You have an NICU which can deliver a 32-week baby and have a great stay and great go home, an intact survival. Then 32 is your time to deliver that baby. You have an NICU which can manage 24-weeker, then 24 weeks becomes it, because retinopathy and neuropathy are hardly reversible. Preeclampsia, the risk of infections are more, malpresentations and cephalopelvic disproportions are more, so they also land up in obstructed labor, birth trauma, increased chances of cesarean sections, postpartum hemorrhage, almost anything and everything that we can think of as complications in 3rd trimester, any GDM can land up in. In addition to this, so when the mother becomes insulin dependent, that is where we get a little more antennas up kind of situation. The chances of all these complications happening are more than 15% than a normal GDM and an OHA or a MNT. In addition, they can have, so generally they start off very early, so they can have early pregnancy failures, nephropathy, retinopathy, ketoacidosis. And like I said, they are at risk of all these problems at least 15% more. Long-term complications, once you diagnose them as GDM, they may continue to remain diabetic. So then they become either type 1 diabetic or type 2 diabetic, depending on what you have seen them for. The GDM may respond to your treatment during pregnancy, then go off once they are on follow-up, but come back as diabetes very early in their life. Like if their parents were diabetic at 70 years, they may come back being diabetic at 40 or 50. So yearly follow-up for them in terms of fasting and postprandial sugar monitoring are very, very, very important. They are also at risk of cardiovascular diseases. Now this was about the mother who was diabetic in her pregnancy. The baby also is not left alone. The baby can have risk of childhood obesity and adulthood obesity. The baby has a risk of cardiovascular diseases to come up in later age, and the baby is also at risk for a type 2 diabetes. Most of this risk increases with the uncontrolled state of diabetes in pregnancy. Fetal complications, madam is ready with a big presentation on it, so I wouldn't touch upon it. And neonatal complications, we would be talking in the panel discussion by Srinath sir and his team. So I wouldn't take it up. I didn't want to put up a thank you slide. I wanted to put up a diabetic slide so that it doesn't stop here, but it continues to be an awareness of diabetes, the awareness of complications in diabetes in the mother, in the baby, and in the newborn child. Thank you so much. Now I call upon Madam Dr. Chitra, our sweet little giant, for her talk on...
Can you see me first? That's important. Now, diabetes, as she has already told, there are of two kinds. One is the pre-existing diabetes, which can either be an type 1 or type 2. And the gestational diabetes, which is, as she has told, which could be identified for the first time in pregnancy. The mother can be an earlier having the diabetes, but she is recognized first in the pregnancy, and also the true GDMs, which come later in the gestation. GDM accounts for about 90% of diabetes in pregnancy, whereas the pre-gestational variety accounts for about 2 to 8%. Maternal hyperglycemia and the resultant fetal insulinemia are the reasons for the complications during pregnancy. So irrespective of the classification, we are only concerned about these two entities, and so the next 20 minutes will be on fetal monitoring in hyperglycemia in pregnancy. This has also been dealt with. What are all the complications of pregnancy, hyperglycemia in pregnancy? To the fetus, we have macrosomia, sudden IUFDs, and sudden stillbirths. And from the fetal point of view, we are more worried about the pre-gestational diabetic mother, because these patients are at increased risk from the early part of gestation onwards. So they are at risk for miscarriage, preeclampsia, congenital abnormalities in the fetus, macrosomias, and IUFDs. And we all know that this is directly related to the HbA1c level in the periconceptional period, and as the HbA1c level increases, the threat to the fetus is also going to increase. So how does ultrasound help you in monitoring these fetuses? It starts right from viability and dating of pregnancy. Then we go on to the mid-trimester to assess the fetal abnormalities, then the growth, macrosomia or IUGR, depending on what type of problems the mother face, and of course in the later part of the gestation to assess the fetal well-being. So coming to the early pregnancy, we all know dating forms an important part of ultrasound. As soon as the patient is booked with us, and when she reaches around 8 to 9 weeks, we know CRL, or the crown rump length, gets measured. And this is the most precise and accurate measurement for dating of pregnancy, because the variability at this period between the intra or the inter population is only about 5 days. So dating by CRL remains the first step. Even if you do not have any nomograms, we can easily calculate the gestational age of fetus based on this simple formula of CRL in centimeters plus the constant number 6.5, which gives you the gestational age in weeks. The need for gestational dating in diabetic mothers is quite obvious, because alterations in fetal growth are based on gestation, because when we call this fetus as macrosomia, which is defined as weight or the abdominal circumference of the baby which is more than the 90th centile for that period of gestation, we need to know the gestational age of fetus. And women with advanced gestational diabetes are rarely allowed to go postterm. So it is very important from the fetal medicine point of view that you date the pregnancy and give them the EDD, because once they know the EDD and 40 weeks of gestation, they will know when to deliver the patient. And clinical decision on lung maturity, elective delivery methods, everything is all based on gestational age and the fetal weight. So step 1 in fetal monitoring is dating of pregnancy. Next is viability, which now with all our newer machines, even as early as 5.5 to 6 weeks, you are able to see the fetal heartbeat. Once you switch on the color and the M mode, you are able to measure them. This is a case of a 37-year-old gravida 4 with previous 2 abortions. She has been a diabetic for the past 3 years on diet control with regular cycles. She comes with at 10 weeks of gestation. Her preconceptional HbA1c was 6.3, and this was the ultrasound picture. So what you see here now is a huge gestational sac. Here the mean sac diameter is 24 millimeter. Yolk sac should always be visualized when your gestational sac is 8 millimeter, and a fetal pole should be visualized when your gestational sac is 18 millimeter or more by transvaginal. So even if the patient comes to you for the first visit and you see a huge gestational sac with nothing inside, then you can safely say that this is an anembryonic gestation. This is another case, an advanced maternal age, 39-year-old gravida 3. She had a previous LSCS. First, she had a full-term baby with birth asphyxia. She lost it. Then a second LSCS was done at 37 weeks, and she was GDM at that pregnancy from 35 weeks onwards, and she came for the present pregnancy directly for NT scan. She had an early pregnancy scan done, viability was established, dating was very clear, but when she came for NT scan, this was the picture. So you know in NT scan, the baby has to have head, hands, legs, limbs, everything. So the crown rump length will be at least 50 millimeter or more with the baby kicking. But what we see is here is a small fetal pole with no cardiac activity visualized when you switch on the color. So this is a case of miscarriage. So in pre-gestational diabetes, spontaneous miscarriage rate is around 7 to 17%, especially when there is an improper management in the preconceptional period. And also when you have a higher uncontrolled sugars, and advanced maternal age increases the risk of miscarriage in these patients. So your second step is early viability scan and fetal monitoring. As against pregnancies where mother is normoglycemic, in a pregnant woman, after your early pregnancy and dating scan, instead of calling her directly for an NT scan, it is worthwhile to monitor her viability in between also. So coming to 11 to 14 weeks, this is a most important period in the fetal life where we do screening for both chromosomal as well as structural abnormalities. And when it comes to hyperglycemia in the mother, the risk with respect to chromosomal abnormality based on NT does not increase at all. It is as good as any other mother. Whereas the biochemical values, when you take the double marker, that beta HCG and PAPA, the mom values of these biochemical markers change. With respect to structural anomalies, apart from the general anomalies which can occur to any babies, these mothers are at specific risk because of these sugars, and hence certain specific abnormalities have to be looked into in these fetuses. This is one of the study where they are re-evaluated the influence of insulin-dependent diabetic mother on nuchal translucency and the first trimester biochemical markers, and they have concluded that in the pregnancies in maternal IDDM, that is insulin-dependent diabetes, first trimester screening for chromosomal defects do not require adjustments in the measurement of NT or beta HCG, whereas PAPA in these mothers are quite low, lesser by 15%, and this forms an important part when you are going to predict the risk for chromosomal, because low PAPA, as we all know, is associated with the Down syndrome, and this risk modification has to be given, and that is why when you have the sending the patient for a double marker, it is important that this history of insulin dependent diabetes has to be written, and the lab also has the responsibility of putting this and modifying the risk. In the second trimester markers, the alpha fetoprotein and estriol also are lower as against a normal mothers, and correction has to be done in these factors. And one important thing we need to observe is, despite the fact that these fetuses are at risk for NTDs, the AFP in the mother remains still low because of insulin dependent diabetes. So when you do a 11 to 14 week scan, it is very important that you do a thorough structural surveillance and document all the parts of the fetus at 11 to 14 weeks, because 59 to 60% of anomalies which can be picked up in your mid-trimester can be picked up at 11 to 14 weeks itself, including a good image of the cardia and also the spine. So at 11 to 14 weeks, we have an important marker called as the intracranial translucency, which is the fourth ventricle. This is the equal to line. This is the section what we take for NT. At that section, if you look at this point, which is the intracranial translucency, that equal to line, if it is normal, it is much more confident that you can be much more confident that the spine of the fetus is normal. So whenever this fourth ventricle is not visualized, then you go and look into the spine carefully at 11 to 14 weeks, so that by about 13-14 weeks, you are sure about the spinal abnormalities. So the step 3 in fetal monitoring is a detailed aneuploidy and structural evaluation at 11 to 14 weeks. Coming to second and third trimester, this is the time when we look into the structural normalcy of the fetus. So as the HbA1c or the glycosylated hemoglobin in the pregnant mother is high, the risk for her malformations also increases. But there are certain specific abnormalities for maternal hyperglycemia in the fetus. That is the caudal regression syndrome. One of the commonest thing which we need to stress and look at is the fetal spine. Varying degrees of vertebral abnormalities, the caudal regression syndrome can present either as a partial sacral agenesis, where your end portion of the sacrum, which has to be tapered, that will not be seen, or it can involve multiple segments, lower lumbosacral spine along with your pelvic deformities. You can also have focal femoral hypoplasia. This is one of the commonest anomalies and one of the specific anomalies in mothers. In fact, in some cases when we find focal femoral hypoplasia, that means one femur is smaller than the other one, then we send and ask the consultant to check on the maternal glycemic status, because this is highly associated with maternal diabetes. And the relative risk is about 200 times as compared to normal mothers. So it is very important that spine is checked in all sections, sagittal, transverse and coronal. And when you check the sacral tip, it is important that you have a little bit of liquor around so that you do not miss out on the lower sacral abnormalities. The next important anomaly which is specific for hyperglycemia is holoprosencephaly. This is very easy because BP dissection is one which we take very commonly, and at that point, if your midline falx is not visualized, you see a fused thalami and a monoventricle or a single ventricle, then you think of holoprosencephaly. They are also at increased risk of neural tube defects, spina bifida, anencephaly and hydrocephalus. This is because of the impaired expression of one of the specific gene, PAX3 gene, which regulates the neural tube closure. Whenever there is maternal hyperglycemia, it interferes with this gene and thereby inhibiting the closure of the neural tube, resulting in open neural tube defects. Fetal phase is another point which you need to look at clearly, because orofacial clefting is also very common in these fetuses. So it is important that fetal phase is seen both in sagittal as well as in coronal plane to document that your palate and the upper lip and lower lips are normal. Coming to cardiac anomalies, we all know pre-gestational diabetes diabetic mothers have a high risk for fetal cardiac abnormalities, which will include the septal defects and also the outflow tract abnormalities. So a detailed echo is very important. Another important condition what we sometimes fail to look at is the accelerated myocardial growth and cardiomyopathy, which can occur in these fetuses. So after a normal echo at 24 weeks, these fetuses can present with this cardiomyopathy later in gestation also. So when these fetuses come for your growth scan or for your end-term assessment, it is important that you look into the fetal heart again to see that you do not have, that the fetus does not have cardiomyopathy. Sometimes it can even present postnatally also. So after delivery also, these fetuses require an echo. Genitourinary abnormalities, which can range from unilateral renal agenesis to multicystic dysplastic kidneys, atresias of the intestinal tract, upper GIT as well as lower GIT atresias are also common with pre-gestational diabetes. So as you see here, the relative risk of all these abnormalities are much higher compared to a mother with normal sugars. So your step 4 in fetal monitoring is detailed structural evaluation of the fetus, including a detailed echo. Coming to the fetal surveillance for preeclampsia, we know that mothers with pre-existing diabetes are also at risk for hypertension, and they have an associated vasculopathy, so therefore their risk for preeclampsia also increases. And hence uterine artery Doppler screening for preeclampsia remains one of the important steps when you are doing an assessment of these fetuses. Coming to macrosomia, that is a fetal the big fetus, which we are all very common with. Commonly, we know that these babies are at risk for macrosomia, but since the definition of macrosomia itself does not have consensus, we have put into practice that any fetuses which is more than the 90th percentile of for the gestational age, the fetal weight is more than the 90th centile for the gestational age, we call those fetuses as large for dates fetus, which can be either a normal, genetically normal macrosomic baby, or they can be a macrosomia associated with diabetic mothers, because the incidence of large for date babies is as high as 45% in case of mothers with diabetes. Significance of macrosomia in diabetic mother is that these macrosomias or these increased macrosomias are asymmetric in the fact that only the abdominal circumference increases much higher than that of the other part of the fetus, as against a symmetric macrosomia, which can be due to constitutional or to various genetic syndromes like Beckwith-Wiedemann syndrome, where all the parameters fall above the 90th centile. The important thing you need to understand about the growth of fetuses in a diabetic mother is there is a significant increase in the fat mass percentage as well as in the percentage of fat. And this distribution of fat, which is seen around the upper part of the body, truncal growth and the abdomen, is very specific. These babies need not be macrosomic. That means their weight can still be within normal level, but the distribution of fat pattern is very specific. So the moment you take an abdominal circumference and you see the skin thickness or the subcutaneous thickness is quite high, then you think of GDM in the background and the hyperglycemia in the background. Can we detect macrosomia early in gestation? Yes, we can. When you do your growth scan at about 28 to 30 weeks and you find that the AC is going above the 75th percentile, then the chances of macrosomia is going to be high in these pregnancies, and those need to be followed up. This fetal accelerated growth you see in the diabetic mothers can be occurs as early as 18 weeks. That means the moment the fetus is exposed to hyperglycemia, it starts changing its growth pattern. And irrespective of the glucose control in the mother, this trigger keeps continuing and these babies can still be macrosomic. So what is the important thing which has an association with this is a maternal BMI. If maternal BMI is also high and these are diabetic mother, irrespective of the sugar control, watch out for macrosomia. So it is important that you do serial scans and plot the growth. Polyhydramnios, yes, many a times, in fact, when the fetus comes for the growth scan, just with the look of the Likert and with the AFI index itself, we go back and see that this patient was done sugar testing only at around 20 to 24 weeks and nothing has been done till 30 weeks. That time OGCT was normal. But when she comes to you at growth scan at 28-30, you find poly of about 23-25. Then you instruct the obstetricians to go back and redo the sugars once more, and then you find polyhyd. Then you find the mother to be diabetic. So Likert is significantly increases as the gestational age advances in these people. Coming to the other end of the spectrum, that is fetal growth restriction. Yes, in a pre-gestational diabetics who are associated with vasculopathy and who have preeclampsia along with gestational diabetes, the fetuses are at risk for growth restriction. But if you find a lowering of the graph, lower downward trend in the growth on a diabetic mother's fetus, irrespective, the mother does not have hypertension, she does not have preeclampsia, but the fetus growth is coming down, then you think about the strict, tight control of diabetes in the mother, and then go back to her history and see what she is eating, how much sugar she is on, insulin she is on, etc., and then alter the management. Does Doppler have a role in diabetes? It does not when it comes to macrosomia, but when there is a fetal growth restriction which is of placental etiology, yes, we do like any other FGR. How do you monitor? You do monitor with Doppler. So to conclude, maternal hyperglycemia is a common problem in India. Risk stratification and screening is essential for all pregnant women. Preconceptional maternal glucose status and good glycemic targets are required for optimal maternal and fetal outcome. Fetal surveillance starts quite early and with anomaly screening in the first trimester itself. Detailed targeted imaging with specific focuses on the systems that can be involved, including a detailed echo, detailed examination of the spine, face, etc. is mandatory in all these mothers. Serial scans and plotting of growth graph helps in identifying the growth abnormalities and aids further management. Whenever PAPA comes down, the risk of Down syndrome increase. But in an insulin-dependent diabetic mother, her PAPA is already low by 15 times when compared to a normal mother or that age group. If the PAPA is so low, it is going to give you a false positivity for Down syndrome. So if you don't give the history to the lab, it does not know. So it will just commute it to the same, because whatever we are doing is to feeding into the computer and getting this reports. So if the history is given, that computer will automatically do the calculation of how much to be removed. And so your final report will be more accurate or more. So that is why history is very important. When you are sending to double marker, send it to labs which ask for history. If you simply write it in a paper, double marker and send, and they are doing it without any of your history, don't rely on that lab. Because there are so many aspects which needs to be filled in, including the maternal BMI, which has a variability, including a twin gestation where one twin has vanished. So you don't give that history to the lab, but the fetal pole is still there. That again has a problem. So that is very important when we do. Yeah, we will move on now to the panel. We will do a little adjustment on the stage. Thank you so much for your patient hearing.
We have arranged two panel discussions. One is from the maternal side, maternal and fetal side, and the second one is from the neonatal and the pediatric side. For the first panel, for discussion of maternal and fetal monitoring.
Dr. Ritu, when and how do you do screening for GDM? Do you rely on fasting blood sugar, postprandial, or you want to do HbA1c, or what is it you would like to do?
So regarding the screening of GDM, I usually follow the ACOG guidelines. Because we are all Asians or Middle East or Asian African, we all belong to a high-risk population. So first visit, GTT, it can start from 6 weeks to 12 weeks, or 4 weeks, or first visit, antenatal visit, we can go for GTT with 75 grams of glucose. And if it is normal, we again do it from 24 weeks to 28 weeks. This is the minimum screening that we do it for all the patients. Then we have to individualize every patient if she has sudden weight gain, or the eating habits are not proper, or taking too much of sugars, or when her mental health is not good. Because we know that the mental health has direct correlation with the increasing of sugars, or she is working into working women, night shifts. So we have to individualize every case, and you can again do one more GTT by 32 to 34 weeks. But minimum 2 GTT has to be done. First visit and between 24 to 48 weeks. 24 to 28 weeks, yes.
So you know now why we took the topic. We had somebody telling that one sugars at 2 hours booking visit is enough, and we have a consultant who wants to do a complete GTT so that her monitoring becomes more strict. So what do you think? What do the delegates feel? Which is as she said, because she wants to have a more tight screening protocol, she is into GTT. So what is, in fact, I can ask Lavanya now, what do you do in your setup? What do you rely upon?
To be very frank, I think I also do the GTT, and I'm more happy to do the GTT because I think it's more stringent, where we can pick up the high risk more better. But then I would try to discriminate depending on what is her high risk. Whenever we are talking about a GTM, I think it's very important that we identify who's at the risk. So we need to know what are her prior history? Is it in a high risk? Even when we talk about any women, so I think the screening comes for anybody even before we diagnose that she's diabetic. So that time we'll have to see what is her family history, what is her previous history, does she have an IUD, does she have a bigger baby, and what is her family history, and is she an obese patient, what is the BMI, all these things fall. If she's definitely under a high risk category, I would say GTT, because then I know I'm picking up her more earlier and then I'm not missing out. If I'm just doing a screening on a low risk patient, and that is when we do the DIPSI method. Of course, DIPSI has come in and it has proved itself. My dear Anu said that, you know, we being Indians itself, we are at a high risk. So we can use it as a screening modality for our low risk patients, but then if they fall into a high category, I would say GTT is something that I would...
Yeah, that is why our national guidelines also relies on the fact that we need to do the screening all over India, not only in the corporate level, in the periphery level, in the PHC level, and even in the rural level. And they have clearly stated that irrespective of whatever is the eating status of the patient, the moment she walks in, do a test with 75 gram glucose, and a value of above 140 is taken as a cutoff after 2 hours. And if she is, does not show any risk at that point, repeat it at 24 to 28 weeks, repeat once again the 75 grams glucose test. And how do you do? Yes, that has also been explained by Anu, and this is also reiterated how you have to dissolve, and if the patient vomits out the whole thing within a few minutes, then repeat the test the next day. If she vomits it after 1 hour, then you continue the test and do it on that same day itself. Yes, Lavanya, now we have diagnosed the patient as GDM. How do you want to counsel the couple?
I think counseling is a very important protocol or a step in any pregnancy, and counseling I think is for anybody, be it the sonology, be it the pediatrics, be it the gynec. I think the crux of success is anything to do with counseling. So I think it's very important for us to be very strict on our counseling, because we saw what Madam presented the first case where she was lost for follow-up, though she was already a pre-diabetic. If she had known what are the complications associated with the pregnancy and diabetes involved, that is that she's a pre-diabetic, if we had really explained to her well, I don't think any mother would put herself or the baby under risk. And I'm sure looking back, there will be a regret. So it's very important that we spend enough time on how do we counsel the couple especially. So it's very important that we tell the mother what are the complications involved. So starting, if we get an opportunity to talk to her or counsel her even before pre-pregnancy, I think the counseling starts from there. So it's very important we identify what is her HbA1c. As such, right now, there is no discrimination saying beyond this you should not conceive, or only after this level of an HbA1c you have to be conceiving. The problem here is if your HbA1c is much under control, we say anything less than 7 or 6.5, the risk of having an anomalous child reduces. If the HbA1c is much higher, the risk of anomalies increase. So depending on our HbA1c, we can see so many times in our clinical practice, and I'm sure all my clinicians will agree here, where it takes a very long time she being on insulin. I've had a lot of fertility patients where they get 20, 24 and 20 insulin throughout the day, and we waited for 3 months, 6 months, she's already 37, 38. How long do I wait? So this is when we counsel them what is the consequences of having an higher HbA1c. We go ahead. So tell her that, you know, good monitoring and making her aware that she is going to have a probability of having an anomalous child is important. And also telling her the long-term consequences of her own health is also very important. So that is when teaching them about a lifestyle modification also would add a lot of weightage, where she herself is going to become very cautious, and we can have a better glycemic control, I would say.
Thank you, Dr. Lavanya. Now, Dr. Kanaka, GDM, this patient is a diagnosed GDM. How do you want to manage, and what is the target glycemic status you set for patients?
See, especially glycemic control is very important. Pre-pregnant status, glycemic control is very important, and FBS should be less than, 95. Yeah. That is 95 milligrams per DL, and PBS should be 140 milligrams per DL, and HbA1c should be somewhere between 6 to 7. This is very important, and glycemic control is very important because of the teratogenicity during that is during first trimester. That is organ development, which is very important. And then we give a counseling, is very important, education, and start a pre-pregnancy with folic acid and stop all the other teratogenic drugs like anticonvulsant, things like that.
Yeah, so we go on to what, how Anu had explained about the medical nutrition first. The diet, exercise, that forms an important part.
Okay,
then
management, first once you diagnose her, that is diagnosis, if it is more than 140, just advise her with exercise and diet, that is medical management therapy, and then ask her to come back after 2 weeks, and then repeat again, and then still the sugars are high, then you put her on oral hypoglycemics or insulin, depending upon this thing, and then again repeat depending upon the, this thing, twice a week or once in 3 days or twice a week we can repeat it, and depending upon that we can manage.
Yes, that's what our guidelines also say. You know? And then, Dr. Mahalakshmi, now you feel who should monitor the patient? Is it the obstetrician, the physician, or you would like to have an endocrinologist to give a proper advice and management?
Yes, ma'am. If you're talking about gestational diabetes, I think it's a team approach, multidisciplinary approach. Starting with the fetal medicine specialist, if at all the HbA1c levels are high, based on counseling, based on the scan, and even if required, the need for termination, based on whatever the requirement is. Starting from a fetal medicine specialist, then coming to a nephrologist, because we all know that diabetic vasculopathy can even hit the kidneys and eventually lead to chronic kidney disease. And it can be such a progressive disorder where even kidneys, will have to be transplanted later on, at the later stage of life. If that has to be dealt with, a nephrologist is to be involved into the situation, and even an ophthalmologist. If a laser photocoagulation has to be done, it is better to be done as early as possible, because we know that vascular conditions can even affect the retina, causing blindness, which is also progressive blindness, not just the early stages of blindness. To avoid all of these, maybe multidisciplinary approach will be needed. Unfortunately, diabetes is just not an isolated disease. It comes as a cluster of diseases with hypertension, with recurrent UTI. Maybe a physician, endocrinologist will be needed, not just for monitoring the blood sugars, but also with other autoimmune diseases like thyroid disorders, isn't it? So we'll need an endocrinologist anyway. Apart from that, I'm not underrating an obstetrician here. The growth of the baby, amniotic fluid index, Doppler indices, and of course the delivery, everything should be planned by an obstetrician. And again, the dietitian, nutritionalist, the nutrition dietitian, who will be monitoring not only not the sugar values, but also advising on diet and exercise. I think they are, all together we're going to do a great job. And of course, neonatologist, pediatrician, I cannot forget them. But at the end of the day, I think we're not just delivering a healthy baby for the mother, but it also matters towards the end, we have to give the mother and the baby a healthy future as well.
Correct. Thank you. How do you monitor the fetal?
I think, ma'am, we missed out the most two stalwarts right next to me. The sonologist has not been added there.
Yeah, how do you monitor fetal well-being?
In case of GDM, what happens is there are two problems that occur as the fetus grows. They can develop macrosomia and polyhydramnios. Now, what develops in utero depends upon the maternal glycemic status. So you need to look for fetal growth and the development of polyhydramnios, and guide the obstetrician, as she just said, to whether the growth of the fetus is occurring as expected or there is accelerated fetal growth, polyhydramnios developing, because this will tell you that the blood sugars are probably not well under control. So that is a guide to monitoring. Second is, if there is an overzealous dieting, a lot of women are paranoid about taking insulin, but that's not the answer. If you do too much of dieting and try to control, when you're not pregnant, that's a good, healthy option, I suppose. But when you're pregnant, the fetus is depending on your nutrition, which the mother has to give the fetus. So that can cause growth restriction. So even though macrosomia is what happens normally, sometimes we see that the growth is not occurring, and when we ask the patient, we see that she is overdoing her dieting. So she needs to be explained that that is not what she should do. She should eat as she feels like, not go hungry, and take insulin or oral hypoglycemics as advised. And if there is vasculopathy, of course, in GDM you don't usually have that, but suppose it is a pre-gestational diabetes and there is vasculopathy, of course, we'll have to look in for fetal growth restriction as well. As it has been already explained, there is anomalies. Anomaly scan is an important part of monitoring these babies. So 18 to 20 week scan for a detailed anomaly assessment, and an 23 to 30 week scan and 34 to 36 week scan are the minimum for growth monitoring. Now, there is, as I already said, there is a tendency for Macrosomia and Polyhydramnios. So if you already see that happening, you might have to increase your frequency of monitoring to every 3 to 4 weeks. And as it has already been pointed out by Chitra, if the AC at 28 weeks is above the 75th centile, you know that there is a higher chance of Macrosomia developing. So closer monitoring for those fetuses is also required.
So this is the final outcome of the fetus, what I was talking about, that IUD. So now you see the reason for IUD. So now we move on. This was a small data of ours. The special thanks to Dr. Geetanjali. We had about 10% of GDM in the last 1 year. The average age is about 29 years with multigravidas being more. The mean gestational age was around 37 to 38 weeks. None of them had pre-existing diabetes, macrosomia. And they had associated problems like hypertension, PIH, and hypothyroidism was seen in 8 of them. 9 of them had well-controlled sugars, 10 of them were on borderline control, and 4 of them had very poor control. Management was on, for 4 it was only medical management, 13 were on tablets and 6 were on insulin. Coming to the mode, 10 of them delivered normal, 8 went on for emergency LSCS for various intrapartum reasons, and 5 of them had elective sections. So apart from one which had atonic PPH postnatally, all of them had minor antenatal problems. The majority of them, nearly 70% of them, had a normal birth weight babies. And NICU admissions were for 11 babies, which was basically just to monitor their postnatal sugars for the next 1 or 2 days, and all of them went home happily. So now we move on to the second case. This is a small case on about pre-existing diabetic. Then we have a small panel on with the neonatologist, and after which I request all the doctors who have assembled here to see our neonatal setup in that maa Kauvery building. Thank you.
Going over to the case 2, we have Mrs. M, 35-year-old, second gravida with over-DM on insulin mixed at 10 units twice a day. At 3 months of amenorrhea, coming to us with an early pregnancy scan which was done outside. Corresponding dates, HbA1c of 8% at booking. Others basically were normal, which means to say she didn't have any other comorbid conditions at the time of we seeing her. Her first trimester screening obviously is pending and she's come for it. The previous pregnancy was basically uneventful till about the 8th month of her pregnancy, where she was diagnosed as GDM, treated with insulin at diagnosis itself, which means it was quite high. In this situation where she is already on insulin at the beginning of pregnancy, what is the importance of pre-pregnancy counseling?
Here, pre-pregnancy counseling we have to do because of the teratogenicity which causes during organogenesis. The blood sugar should be within normal range, and HbA1c should be between 6 to 7 is ideal. And then she has to be in case if it is very high, then we have to refer her to the endocrinologist or a physician to manage the blood sugar levels.
Yes. So ideally we would want to change her to a safer oral hypoglycemic if she is on a teratogenic oral hypoglycemic, preferably metformin, or
insulin should be
insulin. Like ma'am said, we should start her on folic acid pre-conceptionally at least 3 months before she is planning on the pregnancy. And of course, we need to get an effective glycemic control at that point of time, monitored by either the home values or the HbA1c values.
And also teach her how to self-monitor the blood sugars,
using a glucometer at home.
Yeah, glucometer at home. And then, and also stop any other high risk if she is on any other anticonvulsant drugs or any other medical problems. If she has to, we have to look into it. And also
going to the next question.
About the fetal outcome also we have to tell her.
Yes.
That's more important.
Correct. To Dr. Mahalakshmi, what are the associated maternal complications that we can think about in her case? To remember, she is an insulin-dependent mother.
Yes, ma'am. Diabetes mellitus as such is associated with infections, be it recurrent urinary tract infections, skin infections, vaginal infections. All these infections can happen in a lot of women. And yes, we see a lot of patients coming with vaginal candidiasis over and over again in spite of regularly treating them, in spite of even having sugars under control. That is one concern. And sometimes hypoglycemic episodes, these women, we are supposed to be educated with how to monitor hyperglycemia and hypoglycemia, what exactly they have to do with hypoglycemic events. And then issues like diabetic ketoacidosis can happen with women. And apart from the medical conditions like renal impairment, eye involvement, and neural involvement, I can also think about the mother with future complications of cardiovascular issues. Then as the pregnancy continues, we can think about polyhydramnios. When vasculopathy sets in, we can also think of IUGR and pregnancy-induced hypertension as well.
Thank you. Thank you, Dr. Maha. The next question goes to Dr. Preeti. Ma'am, what are the associated fetal complications that we can anticipate in a mother who is insulin-dependent diabetic?
In insulin-dependent diabetic, the pathology, the disease is present prior to the onset of pregnancy. So the embryonic period is affected by abnormal sugar values, and therefore diabetic embryopathy is an important component of this condition. So neural tube defects and cardiovascular defects are the most common. They also have other abnormalities, but as already been pointed out, sacral agenesis, caudal regression are more common in diabetic mothers. Miscarriages, that's again due to embryopathy. Miscarriages is common. Placental insufficiency can develop. If there is associated placental pathology, these mothers can develop PIH as they go on, and that can also cause fetal growth restriction. If they have pre-existing vasculopathy, again that can cause fetal growth restriction. And intrauterine demise can be the ultimate if sugar control is not maintained and she is not monitored properly through the pregnancy.
Ma'am, I think we would be all interested in going a little detail into this part of it, where we would be all looking at GDM mothers who are specifically GDM after their 7th month, 8th month, but then somebody comes to you as a pre-gestational diabetic, needs little extra care and probably little less in numbers for each of our care. Let's do it in a little more detail. Ma'am, would you like to explain a little more on that?
Okay, so the teratogenic effect in pre-gestational diabetes is because of hyperglycemia. Hyperglycemia is the main culprit. In addition, there are many other abnormal hormonal and electrolyte values that will affect the fetus adversely. This includes hyperketonemia, abnormal metabolism of arachidonic acid, myoinositol, and prostaglandins, and oxidative stress, which increases the free oxygen radicals. Now, what happens in embryopathy is the hyperglycemia causes an increase in the oxidative stress. It damages the cell membrane. It causes mitochondrial dysfunction and abnormal apoptosis, which leads to congenital defects. When there is maternal hyperglycemia, there is also osmotic diuresis. This causes volume depletion in the mother, which affects the uteroplacental circulation. Decrease in the uteroplacental circulation causes hypoxia and acidosis in the fetus. Now, hyperglycemia and hyperinsulinemia per se increase oxygen utilization by the fetus. So even without the maternal effects that I said, these fetuses need good amount of oxygen. If there is any decrease in the amount of oxygen supplied to the fetuses, they soon become hypoxemic and acidotic. And that is what leads to what we call unexplained fetal demise in these babies.
I felt like I was in my physiology class. Thank you, ma'am, for that elaborate presentation on how it actually works. Next question also, ma'am, if you would take, importance of the first trimester and the second trimester detailed scans.
Yeah, so as we have already been saying, the first trimester scan is very important. First, for dating and viability of the fetus. And as Chitra had pointed out, you need to follow this up. Don't just stop with the first viability scan. By the time you reach 9 weeks, the fetus may not even be alive. So do one more scan to make sure that the fetal growth is happening. Early fetal growth restriction is known to occur in pre-existing diabetes. Then, of course, you have to look for congenital anomalies. As Chitra again has pointed out, almost 60% of the congenital anomalies that you pick up at fifth month will be picked up in the first trimester itself. So you could look for these anomalies. And then once you know what the situation is, you can counsel the patient adequately, and any intervention needed can be done. For example, if you have a twin gestation and one is abnormal, then fetal reduction has best outcomes when done in the initial period, that is by 16 weeks. One more thing I'd like to add is this is again a time to reiterate that it is how the outcome of this pregnancy would be. And it is very important to tell the patient, if you had blood pressure, high blood pressure, complicating your pregnancy, there's very little we can do about it. We can control it, but the fetus is still going to be affected. In diabetes, if you're going to control the diabetes, just bring the sugars down. Keep your glycosylated HbA1c under control. You are likely to have a healthy baby. Nothing will happen to your baby provided you are compliant and do your best to control the sugars. That is very encouraging for them because they know they are under control. So, of course, with all that, there are the non-compliant ones, but you can encourage them to be more compliant. Now, when it comes to controlling the sugars, glycosylated HbA1c is very important because it tells you what the sugar control has been like. As you see in this slide, maternal HbA1c of 7.4% is associated is with only 3 to 4% risk of congenital anomalies. Now, this is older data which we are all familiar with. And as the HbA1c value increases, the rate of abnormality increases. However, it has been recommended that if you have a HbA1c of 10 gram% or more, you can counsel these patients not to get pregnant till their values come down to 6.5. 6.5 is an ideal value to try for conception so that the congenital anomaly rate is the lowest. So this is what has happened over the years. When we studied in the 80s and the 90s, the commonest other than GDM, the group that caused pre-gestational diabetes was the type 1 diabetes. Whereas now the bulk of the non-GDMs, that is pre-existing GDMs, are all type 2 diabetes, and most of these are obese diabetics. In this group, besides hyperglycemia, the obesity itself also has a teratogenic effect, and so the rate of congenital anomalies is higher. So this is a recent study that showed that at 7.4%, the risk of congenital anomaly is as high as 10.2, and in that 8.1 are major anomalies. So it is very important that you bring it down to 6.5 before they embark on a pregnancy.
Thank you, ma'am, for that elaborate explanation on what to do with the management part. Dr. Ritu, would you like to answer the management of an insulin diabetic mother?
See, the management starts first with a lifestyle modification. So first thing we have to ask them for the dietary management. So regarding the diet, they have to cut off their sugars and the high carbohydrate or the simple carbohydrate. They have to stick more to the complex carbohydrate, and we have to ask them to take more of wheat instead of rice. And millets are better option, and then they can go for ragi and jowar, bajra, these kind of things. And then they have to, with carbohydrates, the percentage of carbohydrate intake should be 33 to 40%, they say the newer guidelines. And the fat, there's no issues in taking fat. There's always a misconception that fat causes more sugars. Sometimes the fat intake will help in burning the sugars. So they can increase the dietary intake as well as the protein intake. And 3 major meals and 2 minor meals will help to prevent the sudden shooting of the postprandial sugars. Number 1. Number 2, the exercise part. So walking, we always see, the guideline says 30 minutes of walking, 5 days in a week. But that is very difficult for a pregnant woman. They can't walk in a stretch for 30 minutes. So to cut off the postprandial sugars, we can always ask them to walk for 15 minutes after the meals, which will help to burn the calories. So in one short 15 minutes, it won't be difficult for them. They won't get leg cramps and all those things. And 15 minutes after the meals it's like 45 minutes in a day. So that is good. And third is regarding the sugar management. So here when we talk about the guidelines, when they say that fasting less than 95 and the postprandial, if they're comfortable, they can do it after 1 hour and it should be less than 140 and 2 hours less than 120. Anyone, they can do it. But so strict, achieving this glycemic index is also very difficult for them. So 95 to 100 is still okay because we don't want more hypoglycemia. We don't want the calorie restriction as well because we need nutrition for the fetus and the proper growth of the fetus. So, so for the target values, we can be little relaxed for the target values. 1 hour postprandial is 140, 2 hours we can stretch up to 130. And regarding the management of the sugars, first we will start with metformin. There are a few data which say that metformin can cause, if it started before 20 weeks, can cause long-term complication of infertility or subfertility in the male fetus. But we are talking about GDM. GDM usually starts after 20 weeks. So we can safely start with metformin. And in one day, 2 grams of metformin we can start with 500 twice a day, or we can start with 850 BD, depending on her glycemic index. And most of them, by proper nutrition, diet, and exercise or body weight control, we don't want them to gain too much of weight. So we are not restricting their intake, but we are asking them to take something like high fibrous food. For example, dry fruits. Again, there is a misconception dry fruits will cause weight gain. It is very healthy. It is essential fatty acid and omega-3 and DHA, which they need. And it doesn't cause any calorie or insulin release for them. If they can take a well-divided meals, like 3 major meals or 2 minor meals, it won't increase the postprandial sugars too much. So this is how we can ask them to do that. And GRBS monitoring and first, most important thing is that they should be always sleeping in the night is again very important. If they sleep properly at 8 hours in the night, it prevents fasting gluconeogenesis. Those ladies who do night shift or they do very stressful work or who are into marketing and sales, they usually are always under stress. Sleep reduction, like sleep deprivation, causes more cortisol release and more hyperglycemia in the fasting. Here, what we are worried about, not about the postprandial sugars. We are more worried about the fasting sugars. We want to keep the mean fasting sugar less than 105, even in the poorly controlled diabetics. So, fourth is mental peace. Mental peace and inner peace is very important for them. Most of the ladies, they have to take care of their personal life, professional life, and they're dealing with it, and it's very difficult for young girls who become pregnant to deal with it. So mental peace, if they have, most of the hormonal fluctuations won't happen, and it will prevent the gluconeogenesis as well. Now, again, the insulin, when to start with the insulin. See, insulin, short-acting insulin, it is very safe to start with Actrapid. We usually give half an hour, 3 times a day we give it, and we always ask them to do the sugar as per the guideline 3rd day. But in the private setup, we always tell patients to do it on everyday basis. At least fasting and postprandial after the meals, they can do it. And the mixed start, as every guideline, Indian guideline, ACOG also says that you should start with mixed start or pre-mixed human insulin. But the very recent guideline says that we should start with Lantus or long-acting insulin and a single dose in the night. If very poorly controlled sugar, we can put safely on Lantus in the night, starting with a smaller dose of 10 units. That will prevent hypoglycemia. See, we are not worried too much about hyperglycemia in the later part of pregnancy. We are more bothered about the hypoglycemia, which is known to cause sudden IODs. So we have to be very judicious how much insulin to start with and how much strict control we need to do it. So here we don't want that HbA1c control to be whatever the guideline says. Because if you start doing that, it will cause sudden IODs and hypoglycemia. And We have to educate the patient as well to find out what are the symptoms of hypoglycemia. Symptoms, sometimes it is very difficult for them to understand these are the symptoms. Like palpitation and sweating. Sweating is something which is very common in pregnancy. So sweating, palpitation, and when they start some unusual symptom, we have to train them. We have to educate them to do their self-GRBS start. And whenever the sugars are less than 70, let them take something sweet. So these are the basic things that, to conclude, diet, walking or exercising, 15 minutes, not again 30 minutes in a stretch, proper diet control, and there's no harm in starting with metformin, even 2 grams a day. It gives a very good control, and there is no fear of hypoglycemia, because insulin, metformin doesn't work on the sugar, it works on the insulin resistance. So normoglycemic patients, it will never reduce the sugars. Only high sugars it will reduce. This is how we use in PCOD patients as well. So metformin safely we can go up to 850 twice a day, and even more than 2 grams we can use it. The guideline has told strictly 2 grams because it causes a lot of bloating and dizziness in some patient, but the patient is able to tolerate. We can put up to like 500 TID or 850 BDN 500 in the afternoon as well. And then if it is not controlled and the sugar is consistently more than 120 or 140 range, then we can start with a low dose of insulin and do a postprandial after every 3rd day. We see the sugar, how it is. If it is controlled, then well and good. Otherwise, we keep on increasing the insulin by 2 units. And again, meditation and Vipassana, I'll not stop here. Meditation and Vipassana are 2 very important things, and I think every pregnant woman should do that. So thank you so much.
Dr. Lavanya, as a last comment on this, would you like to enumerate what more precaution in terms of using our friends around that you would want to do for this patient?
I'm assuming most of them know Kannada, so I always say, solpa solpa pade pade tini utana, exercise na, solpa solpa matte matte maadi. So eat little, eat frequently, work out small meals frequently. So after each meal, 10 minutes walking, I think, if they do it stringently, I think we would have a good glycemic control. We could send home a healthy mother with a healthy baby and a bundle of joy. Thank you, and I would like to thank Dr. Chitra and Anu for this wonderful panel.
Thank you. Thank you so much. Dr. Preeti Venkatesh. Dr. Lavanya Kiran. Dr. Ritu Chaudhary. Dr. Mahalakshmi. And Dr. Kanaka Santosh. We are extremely thankful to all of you that you could take time off from your schedule and be with us today. Now I invite Dr. Srinath to take on the stage.
We would be very excited to take you for a tour of our new facility. For that reason, I'm going to give you good news. I'm cutting down 30-minute panel discussion to 10 minutes. And and I will try and finish it off as early as we can. And after that, we can go to our new facility and we can have a high tea over there. Thank you. So, managing pregnancy, the ultimate goal is to have a healthy baby and send these babies with the parents, right? So, however, as discussed, there are many complications can happen to babies who are born to these mothers. So in the next few minutes, we are going to discuss about neonatal outcome and management of IDMs. For that, we have a small panel, being a neonatology team. So we are not as big as the obstetric team. So we have a small panel. We got Dr. Bhaskar, consultant pediatrics and neonatology, and Dr. Kiran Raghu, consultant pediatrics and neonatology, and we have a visiting consultant, Dr. Harika. She is a pediatrician and she works at Sprouts Children's Clinic. So what are the objectives? We'll discuss briefly about the effect of maternal diabetes on the fetus, and also review morbidities encountered by these IDM babies, and discuss the management of these IDMs, and also discuss prognosis for IDM and review follow-up needed after the hospital discharge of these babies. You can see a happy baby actually. That's what we want to see. All the babies to go happy and make the parents also happy. That's what your obstetricians do also want, right? So Approximately 6% of pregnancies are complicated with maternal diabetes, and 80% of which are gestational. And maternal hypoglycemia can result in fetal hyperglycemia and then secondary fetal hyperinsulinism. As a result of that, they can have many complications. So insulin is the main growth hormone of the fetus, and therefore the infants of diabetic mothers are often macrosomic. And there is, as Dr. Chitra has said, there is different schools of thought about what is the weight. I have just put it as 4 kilos. It could be 4.5 kilos also. But we'll take it as more than 98th percentile for gestational age, as Dr. Chitra has mentioned. The problems associated with being IDM relate to the effects of hyperinsulinism and also macrosomia. And macrosomia is due to excessive fat deposition and visceral organ hypertrophy, sparing the brain and the kidney, and acceleration of body mass accretion. So macrosomic IDMs have higher rate of neonatal morbidity and mortality. So these are all the morbidities that can happen. So macrosomia and hypoglycemia are one of the commonest. They also can have ODS, and some of them can be growth restricted babies. Also metabolic problems like hypocalcemia, hypomagnesemia, and these babies are more likely to be jaundiced, and they have chances of having congenital anomalies and polyhydramnios and hyperviscosity syndrome, and cardiomyopathies, and increased fetal death, as well as postnatal problems. So by definition, an infant of diabetic mother is a baby who is born to mother who has diabetes. The phrase specifically refers to the baby who is born to mother who had persistently high blood sugars during the pregnancy. So what is the mechanism of fetal morbidities? So maternal diabetes lead to congenital malformation, as discussed earlier, especially if it happens very early in the first trimester. And maternal hyperglycemia stimulate fetal hyperglycemia and fetal hyperinsulinemia, causing macrosomia and other complications, and ODS and neonatal hypoglycemia and increased metabolic rate, as discussed by Dr. Preeti Venkatesh. This is the pathophysiology. So the more fat is stored in the adipocyte, more glycogen is stored in the liver, and the heart may develop asymmetric septal hypertrophy, and lung metabolism is altered to delay the appearance of mature surfactant. So macrosomia can happen in 1/4 of the insulin-dependent mothers, and excess growth happens in the 3rd trimester. And GDM mothers have same incidence of macrosomic infant as the diabetic mothers. And birth injuries are quite common in these babies, especially when they are delivered through vaginal delivery. They can have brachial plexus injury, fractured clavicular humerus, and facial nerve injury, capillometoma. Shoulder dystocia is increased by 2 to 4-fold, and hypoglycemia, increased risk of asphyxia because of the hypoxia, and increased recurrent risk in the mother. So the morbidities are up 4-fold in these babies, and malformations can shown to occur before the 8th week of gestation, and there are various reasons it can happen, as discussed in the earlier, where you can see spinal abnormalities, sacral dysgenesis, and this is a very severest form of caudal regression syndrome. It's called mermaid syndrome, which is lethal. Other anomalies also reported, like cardiovascular, musculoskeletal, CNS, and incidence is decreased with the tight glycemic control in these mothers. So respiratory distress syndrome, increased risk of RDS in babies who are born to less than 37 weeks with the IDM, and possible insulin interference with surfactant composition and delayed maturation of the surfactant system could be the cause. Metabolic complications like hypocalcemia, hypoglycemia, and hypomagnesemia are common. And hypoglycemia can occur up to 25% of all IDMs, and half of the hypoglycemia occurs within the first 24 hours, and less likely when the mother's glucose is tightly controlled. That's where the obstetric care is so important. And maybe some majority of the babies may be asymptomatic, and a Pedersen hypothesis, it was come into place 50 years ago. Pedersen actually mainly dealt with the mothers who are diabetic, and he proposed that majority of the complications are happening because of the maternal hyperglycemia causing fetal hyperglycemia and hyperinsulinemia leading to macrosomia. Hypocalcemia and hypomagnesemia occurs more in insulin-dependent diabetic mothers and decreased PTH secretion in these IDMs, and they may also have decreased calcium transfer, and some of these mothers may also have low magnesium levels to start with. And polycythemia and hyperbilirubinemia are also common. They are interrelated, and it is secondary to fetal hypoxia, stimulating erythropoietin, causing hypopolycythemia and hyperbilirubinemia, and ineffective RBC production. And polycythemia can also lead to hypoglycemia and may be associated with renal vein thrombosis if it is not acted upon very soon. So how do we manage these IDMs? As discussed in your panel, very tight control, and I'm not going to go into that. We need to consider these babies always at high risk and follow basic steps of resuscitation at birth and post-delivery. Observe and evaluate for any hypoxia, respiratory distress, look for any birth injuries, look for malformations, look for macrosomia, hypoglycemia, respiratory distress. So imaging forms a quite important part in these babies wherever it is indicated. For example, we do a chest radiograph to look at the chest expansion, to look for the evidence of any focus or diffuse atelectasis in babies who are respiratory distress, and also to look for evidence of interstitial fluid and any free air. Echocardiography is important. We have a bedside echocardiography machine, and both Dr. Dinakar and myself are trained in neonatal echocardiography. Also, we have a backup of good cardiology team. And the common conditions can happen is hypertrophic cardiomyopathy, also VSD, and TGA and DOR are also possibilities. And also imaging like abdominal, pelvic and lower extremity radiographs can be used sometimes to look for sacral agenesis, hypoplastic femur, and defects of the tibia and fibula, and flexion constructions of the knees and hip and club foot. So various things can happen as and when it is required, so we can do those. And also some babies may require barium enema, especially the infants with feed intolerance and abdominal distension and non-bilious emesis and poor passage of meconium. And classical features usually seen is distal tapering of the colon in these babies. So now coming to case scenarios. So we have 6 case scenarios, but we will do it very, very quickly. We won't take much time. Okay. So first scenario is to Dr. Harika. You ready?
Yes, sir.
Okay. So this is baby G. He is a 37-weeker IDM. Birth weight is 4 kilos. And born by normal vaginal delivery and good obgas, no complication with the delivery. And baby is with the mom, and baby was breastfed at 2 and 5 hours of age and presents at 10 hours of age with history of multiple apneas and severe lethargy, jitteriness, pale and mottled. So what are the things that are going through your mind?
Yeah, so here as we are having a detailed notes from fetal experts and gynecologists, so there's a hyperglycemia that is cut off by clamping the umbilical cord at birth. So, but unfortunately there's a hyperplasia of beta cells in the baby, so the insulin is produced. So initially we'll expect a transitional hypoglycemia that is quite normal. So we'll try giving some oral fluids formula.
In fact, you're right, GRBS is only 30.
Yeah. So this is the most common thing. So this is what we anticipate when we are, seeing infant of diabetic mother. So as it is rightly written, we will try giving the oral fluids or feeds, and then if needed, if it is not correcting, only then we will go in for an IV correction. And 22% of the IDMs are also associated with hypocalcemia. So it is better to monitor calcium at 12, 24 and 48 hours of life.
So anything you would like to add, Dr. Kiran, Dr. Bhaskar?
So So basically, any baby born to diabetic mothers, we need to have a close look for the blood sugar levels, the pattern of feeding need to be closely monitored.
Yeah, so we have a guidelines that we follow the blood sugars at 0, 1, 2, 4, 6, 12, 24, 26 and 48 hours of life.
That's true. Actually, just like you have different schools of thought about what is the definition of macrosomia, we also have different schools of thought about how to manage neonatal hypoglycemia. In fact, I was going through various books. Each and every book suggests their own. Okay? And but one thing which I found which very pragmatic is American Association of Guidelines, Neonatal Hypoglycemia Guidelines, where it says there is no point checking the sugars in the first hour of life because most of them will be physiologically low. So we end up actually treating these babies unnecessarily. So what they suggest is in the first 4 hours of age, give an initial feed as soon as possible, within 30 minutes or at least within 1 hour. That's where we need the help of the obstetricians to make sure that you prepare the mother to put the baby early on the breast, especially within 30 minutes of life. And after half an hour after the first feed, check the sugar. Depending on that, you take an action. If the sugar is more than 25, then give another 1 feed and then check it after 1 hour. If it is less than 25, straight away you can start IV glucose. Similarly, they have divided monitoring within the first 4 hours and then 4 to 24 hours. That's where the majority of the neonatal hypoglycemia happens. And within the next 24 to 48 hours, the chances are really less. And this is something probably we can all look into. It is widely followed by many pediatricians across. So the management, as Dr. Harika said, we'll initially give the oral feeds. If it's not possible, then we can go for IV fluids. In some babies, the glucose requirement can be very, very high because of the hyperinsulinemia causing profound hypoglycemia. Sometimes they may even require higher dose of glucose. And if that is required, then if the baby requires more than 12.5% of dextrose, we need a central line and then admission to the NICU for sure. So second case, this is to Dr. Bhaskar. Yes. So this is a 2.1 kilo baby, term baby, born to diabetic mother. The baby is currently on full feeds. Baby has normal GRBS. Presents on day 2 of life with cyanosis, lethargy, respiratory distress, and convulsions.
Hi, welcome to maa Kauvery. This is 2.1 kg, that is SGA baby.
Yes.
In her case, gynecologist done a good job. I can't say they have done a bad job here. Even then, the poorly controlled sugars in the mother, which has led to an SGA, that is 2.1 kg, and normal GRBS on day 2. Then had a cyanosis, lethargy, respiratory distress, and convulsion. Okay. So usually, when this child comes, if I clinically examine the child, if child is looking plethoric and lethargy, the one thing which pops up on day 2 especially is a polycythemia. Day 2 being because they lose extracellular fluid on day 2 or day 3. So that polycythemia will definitely increase. Yes. Okay. Then we check routine, we send all investigations. If we had a conversion, better to send hypocalcemia and calcium level and magnesium along with to make sure that it's not hypocalcemia and hypomagnesemia. So in this case, we already have a report here. So it's too fast in a lab. So PCV is 66 and HB is 22. Definitely it's polycythemia. Basically, and it's symptomatic because child has presented with convulsion and lethargy. So at that point of time, definitely we need to treat with partial extent transfusion. Why polycythemia? Preeti madam also explained why it happens in a pre-gestational diabetic where they go through fetal acidosis, oxidative stress, which lead to polycythemia in the babies. Okay, I'm not going in detail with that. So it's a polycythemia, needed to treat it with a partial expression. We got an NICU admission for this. So, and one child, as madam was telling, we have done a GDM child in our hospital, a partial extent transfusion. Take care.
We definitely need to prevent further complications like hematuria, neck, PPHN, these babies, and also The preventable CNS morbidities in these babies is hypoglycemia, microcephaly, CP, cerebral palsy, learning disabilities, and hemiplegia, cerebral infarct, and mental retardation. Case 3, this is to Dr. Kiran. So it's a term baby, 3.8 kilos, born to infant diabetic mother, presents on day 3 with respiratory distress, 80 per minute, quite tachycardic and very poor pulses, and saturations are 94. So there is no cyanosis, okay? But there is a features of congestive cardiac failure and there is a murmur. So what are the things that are going through your mind?
You know, the things to consider here is respiratory distress with tachypnea of 80 per minute. So commonly, IDM babies, they have respiratory morbidities in the first 2 days. But we also need to consider some non-respiratory causes of respiratory distress. So as Dr. Chitra had mentioned, these babies are at risk for asymmetrical septal hypertrophy, which can present as tachycardia, congestive cardiac failure, systolic murmurs. So I would think about a cardiac cause for this babies.
You are perfect. Perfect diagnosis. There is hypertrophic cardiomyopathy.
So any baby who has come with features of congestive cardiac failure, we normally take care of the baby's respiration, the airway breathing. In the circulation part, we try to restrict fluids. We give Lasix if there are features of CCF. It's also important to do an echo immediately because having ruled out, having known that there is hypertrophic obstructive cardiomyopathy, we may have to avoid a few medications, for example, dopamine. So in cases with poor perfusion because of the cardiomyopathy, dopamine can aggravate the shock in such babies. So we need to do an echo. So all the features of CCF, if it's seen along with the history of diabetes, then we may have to start the baby on Lasix, propranolol. And unlike other complications which can be treated, over a period of 2 to 3 days, the cardiac issue may have to be treated over a period of time.
So this is for you, Dr. Bhaskar. So it's a term baby, 39 weeks, elective C-section, birth weight is 3.7 kilos, born to infant of diabetic mother, and presents with severe respiratory distress at 1 hour of age. Unlike the other baby which is presented on the 3rd day, this is present at 1 hour of age. So what are the things that are going through your mind?
Kiran has covered cartilage part, so it will be leg part. So respiratory distress syndrome in 1 hour of age usually it's when involvement of lung. Either in considering a GDM in the case which we are dealing today, it should be either and surfactant deficiency, RDS, or TTN, which is most common than RDS in this.
Perfect. So how do you differentiate?
See, okay, you already have a picture here. See, RDS, you can see there's a diffuse, symmetrical, granular, typical, nice photo, sir. Okay, and a small lung volume compared to the TTNs. And TTN, there is an arrow mark which is very evident there and which shows an intralobar fissure edema. Okay, that's a line there. Huh? Transient tachypnea of newborn. Okay. Yeah. See, transient tachypnea of newborn, there is an intralobar fissure, there is an edema, which suggests you there is a lot of fluid accumulated there. So, child in RDS, the treatment remaining, depending on the requirement, if we give on CPAP or ensure horse or ventilation, it depends on the individual case. For transient tachypnea of newborn, child will treat himself. So, majority of the times. So very in malignant conditions, malignant TTN we call it as. So in that require little NICU stay. Otherwise, most of the child will come within 2 to 3 days.
It's a self-limiting condition, usually 48 to 72 hours. Majority of them will settle down. Just a supportive treatment. So next case is to Dr. Kiran. 4-day-old baby, preterm, IDM at 36 weeks, birth weight is 1.8 kilos. Presents with feed intolerance, vomiting and abdominal distension, and also bilious aspirates. So what's going through your mind?
So here there is GI symptoms of feed intolerance, vomiting, abdominal distension, which is presented on the 4th day. So IDMs are at risk for GI anomalies. I mean, they are at risk for atrasias all through the GI tract. So it's presented on the fourth day, means it's something which is lower down and it's with abdominal distension. So it's probably some form of an obstruction in the lower GI tract.
I think you're spot on. That's right. It's a small left colon syndrome. Okay. So you want to tell more about it?
Yeah. It's not clearly known why the sigmoid colon and the lower sigmoid colon, why it's poorly developed in these babies. But it's kind of a transient, can be a transient condition most of the times. Most babies require some form of rectal stimulation. They may need to be kept nail per oral for a period of time. They need serial check X-rays to see how the obstruction part is resolving. So most of the time it's a self-limiting condition.
And
very rarely it
is
requires.
both diagnostic as well as therapeutic. So last case, Dr. Harika?
Yes, sir.
So you're the first one to start and last one to finish, okay? So we have it, so you are, since you practice outside, so you've been called to attend a delivery in the nearby hospital, and you attended delivery at 38 weeks, and infant of a diabetic mother, birth weight is 3.8 kilos, by normal vaginal delivery, but it was quite a difficult extraction. But fortunately the UpGars were good after that, and you're very happy that the UpGars are good, and you advise them about the feeding and monitoring the sugars, and you went home. Next day when you go for the rounds, this is what you see.
This is a classical, waiting tips position.
Waiting tip position, yeah. Yes, exactly.
So, yeah, you can see the shoulder rotation, and the arm is pronated, extended, and then the wrist is flexed. So this is a clear spotter of Erb's palsy. This usually happens whenever there's pressure during the delivery at the baby's face, neck, or the shoulder. There's injury of C5 and C6, which is affecting the axillary nerve, musculocutaneous nerve, and supraspinal nerve. Basically, this brachial plexus can be of 4 types. The first one is neuroapraxia, where there is only stretching of the nerves and it is very much self-limiting. The baby will recover in 3 months. The next one is neuroma, whereas there's a little bit tear of the nerve fibers. It won't heal completely, but not much of an issue. The third and the fourth type is the tear itself or the avulsion. The avulsion that is happening, the tear at the spinal level. So these 2 things are like concerning. These babies might require a nerve graft or nerve transfer at 9 months of age. Whereas the first 2 things, usually they recover by 3 months of age. So once you see this thing, we'll have to refer them to an orthopedician and counsel the parents so that they will be prepared. And then the first 2 weeks, we have to wait for the nerve injury to settle. So handling the baby is very important. Don't give pressure on that hand. Put the baby on the opposite side of the injury, or make the baby sleep on the back. And from 2 to 3 weeks, we can start off with physiotherapy. The physiotherapy will target on a range of motion at the shoulder, arm, elbow, and the wrist. So, whatever the damages of the 4 types, by 3 to 6 months, we'll have a vague idea about how the child is progressing. So, at 3 to 6 months, there is no improvement. Then we have to plan a surgery microsurgery around 9 months. The reason why we are doing it early is because it will help in the baby's development.
So one thing I need to add here, the counseling of the parents is very important. The gynecologist and the pediatrician should be on the same line, so that
yes,
the blaming should not go on any one of us. Okay, thank you.
That's very, very important. Joint counseling really helps in these cases. Yeah. So we are coming to the end. So the prognosis for these babies, the majority of the IDMs are likely to be obese. And macrosomic infants are 6 times likely to be obese at the age of 7, an increased risk of teenage obesity, and these children, as the young adults, can be at risk of metabolic syndrome, and no developmental problems have been noted for asymptomatic hypoglycemic babies. So that's what we need to be at least happy that. So which are the factors influencing the severity of the neonatal adverse outcomes? It is not constant in all cases, but definitely quality obstetric care as provided by the experts like you play a significant role, okay? And most of the complications are more likely to happen in macrosomic babies. And in conclusion, At maa Kauvery, we are well equipped to handle all the emergencies and complications related to IDMs. We have multi-speciality team of radiology, orthopedics, cardiology, neurosurgery, neurology, gastroenterology, nephrology, which can definitely come and help us if required. But I believe that our both fetal medicine and obstetric care is fantastic, and we don't end up with many complications. In case if there are any complications, we're always there to handle. Thank you very much for your patient hearing. Oh.